Welcome and thank you for joining our Men's Health webinar. I'm your host, Margaret. We'll start with a few housekeeping items and then I'll introduce tonight's speaker. First, your participation in tonight's webinar is completely anonymous to the other attendees. No one can see your face, your name, or hear you. If you wish to ask a question, please type it at the chat box at the lower part of your screen, and we'll address these questions at the end of the presentation. Any comments or questions entered into the chat box can only be seen by myself and our speaker. Our presentation tonight will last for approximately 1 hour and be presented by Dr. S. Flint McFerren of the Urology Clinics of North Texas. Dr. McFerren is well-trained in all aspects of general urology with a particular interest in the minimally invasive surgery of both benign and malignant urologic conditions. He utilizes a Da Vinci robotic system for the surgical treatment of several conditions, including prostate cancer, kidney cancer, urethral stricture disease. He has a particular interest in urethral reconstruction with oral mucosal substitutions, as well as the use of prosthetics for erectile dysfunction and urinary incontinence. Thank you for being with us tonight. Dr. McFerren, I'll turn it over to you to get us started.
Okay, perfect. Well, no, thanks for that introduction. Like she said, I'm Clint McFerren. You can go to the next slide. And, I practice here with Urology Clinics in North Texas. I think most of you guys are, are patients of ours at one of our two locations here at Medical City, Dallas at Forest Lane, or in Plano at Baylor. But tonight, what we're going to do is September is Prostate Cancer Awareness Month. And so we're going to discuss, some aspects of prostate cancer, and that's fine. You can keep going to the next slide, and then we're going to go over, a few things as far as treatment of prostate cancer, and some of the side effects of treatment and how we deal with those. We'll start from kind of a very basic level, okay? And the prostate, really is this walnut-sized gland, and you can see it here depicted right at the base of the bladder. And the urethra, or the P-tube, goes through the prostate, from the bladder through the prostate, and then, of course, out the penis. And so treatment, of the prostate, whether it's for cancer or whether it's for benign enlargement, will, of course, affect the way that we void because, the urinary tract goes through the prostate. But the primary function of the prostate is that it just gives some fluid to the ejaculate. It's really not a very helpful organ. I mean, it's necessary, but certainly there are more vital functions in the body. But that's essentially what the prostate does. So, one thing that'll be important, in our discussion is to make the differentiation between what we call BPH and prostate cancer. BPH, or benign prostatic hyperplasia, if you ever diagnosed with that, or if you ever see that on an image that's been obtained, then what that is that just means enlargement of the prostate. And we know that every man's prostate will grow as he ages. And of course, some will grow more rapidly and some will start larger than other men. That's based primarily on genetics, but everyone's prostate will grow with time. But in some settings, prostate cancer and BPH can have similar symptoms or may present that way because they affect the way that we void. Next slide. So, you probably know this, but prostate cancer is exceedingly common. After skin cancer, it's the most common cancer that we diagnose in men. And survival rates are quite high, as we'll discuss. And these are some more numbers you can see as far as, the number of new cases diagnosed, the very high survival rates for localized disease, And I guess, the overarching message, when you look at these numbers is prostate cancer is common. And when it's diagnosed, okay, it's very rarely aggressive or fatal. And so that's meant to give you reassurance. If you're listening and you have prostate cancer, you've been diagnosed, of course there's some bad actors. Of course there's some prostate cancers which are which are serious and require extensive treatment. But a large amount of them are simply there, and they don't typically shorten our lives. And so don't feel alone. But anyways, so getting into kind of a little bit more about prostate cancer, typically this is a disease of the aging man. We typically and you'll see this in future slides, for the average risk man, we don't really start screening until you're probably 50, or even some at 55. And men that are higher risk, okay, and this is key, who's higher risk? That's one of the questions that's very important as we think about screening and awareness. Men with a family history are at higher risk, so anyone, especially with first degree, male relatives like a father or a brother, you would be at higher risk. Conversely, if you've been diagnosed with prostate cancer, then it's really important that your son or your brother are being screened appropriately because they'll be at an elevated risk. Okay. I think a lot of people have questions about their children more than they think about themselves. The other thing is that, African-American men, are almost twice as likely, to be diagnosed with prostate cancer. And so, those two things, race and as well as family history, are really the primary risk factors. Okay. And I won't be saying everything on these slides. Okay. So these, I will kind of give you the high points, and this, again, I kind of talked about this, as we start with kind of the discussion of screening, like how do we even detect prostate cancer? Typically in the average risk man, like I said, we start at age 50. I think for those that are high risk, which again, those risk factors that I just discussed, we may start earlier, like 45. And if you're really high risk, we may even get a PSA or start screening every so often at age 40. Okay, next slide. So, how do we screen you? That's the question. So when do we start, and then how do we screen you? Most commonly we screen with the PSA blood test. And I get this question a lot. This is a blood test. This is not a urine test, okay? And not all primary care physicians are super vigilant about testing, this, because PSA has had its controversy over the years. But what we know is that, certainly PSA can be a very helpful test. Now, one thing I'll say about PSA, when it's low, okay, PSA is a great test. You very rarely, almost never have cancer if the PSA is low. However, when the PSA is high, so say we check it and it's above 4, it can be high for a variety of reasons. That doesn't always mean that it's high, due to cancer, okay? And so it can be high because of inflammation, infection, just an enlarged prostate can cause an elevated PSA. So just because your PSA is high doesn't mean you have cancer, but it does mean that we probably need to look, more deeply into this and evaluate it. Also, of course, we'll be doing, the infamous prostate exam to try to detect any nodules or irregularities. And then other tests that we may escalate to, like if the PSA is abnormal or if the rectal exam is abnormal, we'll jump to an MRI. We may do some genetic testing. These are ways to give us kind of more information. I just told you the PSA is kind of finicky, right? And it can be high for different reasons. And so one way that we can kind of, narrow in on more definitive data is to get other tests such as MRI or genetic testing. Okay, next slide. But the main way that we diagnose prostate cancer is with a prostate biopsy. Now, there are a variety of techniques now to do this. I think traditionally, this is a transrectal biopsy. This is where we put an ultrasound probe in your bottom, and we use that to visualize the prostate and to take several samples from the prostate. Now there's an alternative technique. I guess it's been around for a while, but it's picking up in popularity, and this is called transperineal biopsy. And this is where we actually go through the skin to sample the prostate. And the benefit of transperineal biopsy really is that it has carried the infection risk really down to zero. Now, our infection risk here at UCNT, even with the transrectal approach, is just 1.3%. So it's not very high, but you can take it almost to zero with transperineal. Now, the problem with transperineal biopsy is that you have to do it under anesthesia because it's fairly uncomfortable. Now, some people will do it in the office, but I think everyone doing transperineal in our group is doing it under anesthesia. And then the other thing I would just add is that we use MRI now to fusion our biopsies, meaning if we see a lesion or we see a spot on MRI, then we have software where we can use that MRI image to target the lesion when we're doing the ultrasound-guided biopsy. I hope that makes sense. But so lots of new and different ways to do biopsies that your urologist can help you get through. So let's say, okay, so we talked about screening. We talked about how we make the diagnosis. What if you're diagnosed with cancer? What's some of the terminology? Well, there's really two things. It's grading and staging. Staging is really is a description of where is the cancer. Is it on one side of the prostate? Is it on both sides of the prostate? Is it in the lymph nodes, or has it spread to other organs? Of course, everyone always wants to know what about stage 4? Because I think that's kind of infamous. What stage 4 cancer would be cancer that has spread to distant organs, okay? Very rarely does prostate cancer present that way. Many times we're diagnosing it in a localized stage, which would be stage 1 or 2. Stage 3 would be kind of it's getting into some of the organs or the structures right around the prostate. What's I think more important is for us to talk about Gleason score, because if you're diagnosed with prostate cancer, then they'll look at the Gleason score. And this is the grade of the cancer. So stage is like, where is it going? And grade is like, how aggressive is it? When we look at it under the microscope, okay, how aggressive is it? And they assign a Gleason score to determine the grade. Next slide. So, and I talked about this already. We can go to the next slide. And so I want to camp out and I want to talk about the Gleason score. Okay. And so typically you'll get a Gleason score with prostate cancer from 6 up to 10. Okay. And the way that they calculate these scores is actually they look at the patterns under the microscope and they assign them 1 to 5, and where it starts to matter is 3, okay? And they find the 2 most common patterns underneath the microscope, and they add those patterns together. So the most common pattern, or the most aggressive pattern that you can have is 5, okay? And if you take 5, and the second most common pattern is, again, 5, then you have 5 plus 5, which is Gleason 10, which would be the most aggressive Gleason score you could have. On the converse, if you have, let's say you have the most common pattern you have is 3. And then the second most common pattern you have is 4. Well, then you have Gleason 3 plus 4 or Gleason 7 cancer. Now, to make it even more confusing, we've recently started putting these into what we call grade groups, okay? So everyone with Gleason score of 6 will go into what we call Gleason grade group 1. Everyone with Gleason 7, the 3 plus 4 type, okay, which is the less aggressive type, will go into grade group 2. Everyone with Gleason 7, 4 plus 3, the more aggressive type, because there's more pattern 4 than there is 3, so more pattern 4 is more aggressive. That'll go into grade group 3. And then the more aggressive types go into 4 and 5. So I just want to go over that so that you understand if you've been diagnosed, where you classify. And you can see there under the risk group kind of going from low to intermediate to high risk. Okay, next slide. So let's talk a little bit about treatment, okay? I think, this is primarily looking at treatment for what we would say is localized prostate cancer, okay? So this is kind of stage 1, 2, or 3. This is cancer that's just confined to the prostate. not, if you've got prostate cancer in your bones, if you've got prostate cancer in your other organs. Unfortunately, these are not great treatments. But one thing that I want to highlight is we're surveillancing a lot of men with prostate cancer. Like I've told you, it's not a very aggressive disease most of the time. And so we have started to surveillance a large percentage of men, mainly that includes the men that have Gleason 6 cancer, or what we would call grade group 1. And then some of the men that have grade group 2, a really low volume disease. We can watch a few of those, okay? But all men with Gleason 6 disease typically are surveillanced. And surveillance does not mean like we kick you to the curb and we never see you again. Surveillance is an active protocol where we're checking your PSA routinely. We're getting MRIs or repeating your biopsy as needed. We're trying to make sure that their cancer does not progress and does not change into one of these more treatment type cancers. If we do have, a cancer that we need to treat, localized cancer, typically we do this with surgery and we do it with radiation. Surgery to remove the entire prostate, and typically radiation to the entire prostate as well. Now, there are various forms of radiation. There are, there's proton therapy, which is out there. There's some targeted therapy where we're just treating only the prostate cancer and not the entire gland. That's called focal therapy. And that is still, I think not quite mainstream. It's being done at academic centers. It's certainly being done in trials. But I think if you look nationally, the mainstay of treatment for cancer is still treatment of the entire gland. That's where we have the most data. Okay. So yeah, I kind of went over this, but active surveillance, like I said, it's a protocol. I mean, it's active. That's in the name, right? PSA tests every 6 months, rectal exams at least annually. You may get imaging, you'll get a confirmatory biopsy, meaning within about 18 months, a lot of times we'll repeat a biopsy. We may repeat an MRI. We'll make sure that it's still safe to watch. Now, surgery, is typically these days done robotically, which is a kind of a fancy way of doing what we call laparoscopic surgery, where we use the Da Vinci robot to remove the entire prostate. We also remove the lymph nodes in the pelvis typically. But yeah, over 95% of prostatectomies in this country are being done robotically. Open prostatectomy, where we use a bigger incision to remove the prostate, is really not done much anymore, except in maybe select scenarios. Robotic prostatectomy, though, usually requires one night in the hospital. I think there's some people doing it outpatient, but I think in our practice, typically at one night in the hospital, typically requires you to have a catheter in your bladder for at least a week, because as we talked about on the very early slides, right, the urethra, the P-tube, goes through the prostate. And so when we remove the prostate, we disconnect the urinary tract. And so we have to put the bladder back to the urethra and sew it together. And then we put a catheter across this connection while it heals. And so that while that connection heals, we leave a catheter, and you have that for at least a week, and sometimes up to 10 to 14 days. It's somewhat of a recovery. It's a surgery. It's an abdominal surgery. It definitely has some side effects. So you can see on the slide, almost every man will have urinary incontinence or urinary leakage after the catheter is removed. Now, most men will regain their continence, and we'll talk about that in some more detail in the later slides. Sexual dysfunction or erection issues can be a problem. A loss of fertility, I guess, would also be a problem because you're not going to be able to ejaculate anymore. But I will say, most men going through prostate cancer surgery are past their years of fertility. So radiation treatment is another option, and this is a very good option. Now, look, when people ask me all the time, what's better as far as curing cancer? Is it surgery or is it radiation? And the truth is that they're equal. When we pulled the data from thousands and thousands of men, the outcomes are pretty equal. Surgery, of course, is what I call hot and heavy. It's a lot up front, right? It's a recovery. It's a catheter. You're leaking urine. It can be challenging up front, but then long term, once you recover, it's pretty nice. The radiation treatment doesn't cause a lot of side effects up front, besides maybe a little bit of urgency with urination or urgency with bowel movements. But, the radiation treatment does take a while. Traditional radiation, typically will take 6 weeks where you go pretty much every weekday for 6 weeks. Now, there's some other types of radiation that don't have the same longevity of treatment, but that's probably the part that people don't like the most. The other side effects of radiation, many of them happen later in life, okay, like scar tissue development in the urethra and the P-tube, a condition called radiation cystitis where the bladder will kind of bleed intermittently. A lot of those happen later. Now, you don't really get as much urinary incontinence or leakage with radiation like you do with surgery, but the sexual dysfunction, the problems with erections, they still happen with radiation. And then, of course, you can have some issues with your bowels because of the proximity of the rectum to the prostate. So we'll just take a little moment to talk about SpaceOAR. SpaceOAR is a way to reduce some of the side effects of radiation or potentially reduce them. This is a product that basically it's a hydrogel, and we inject this hydrogel spacer in between the prostate and the rectum. And the reason we do that is we're trying to give space, between those structures so that when we deliver the radiation to the prostate, there's potentially less effect on the rectum. And that hopefully can lead to less issues with bowel dysfunction, with diarrhea, with proctitis, and those sorts of things. And so there is some data to suggest that this product can help. Next slide. And so you can see this is just one of the studies showing, the effectiveness of those who've had SpaceOAR. And so you can see in the graph there, sorry, I'm going to lean forward so I can see, you can see the gastrointestinal side effects and the urologic side effects are decreased significantly in the patients who had a SpaceOAR placed. And, like I said, it's an absorbable hydrogel. It's been studied. It's safe within the body. It's typically put in the clinic. It's done under local anesthesia. We'll inject some numbing medicine and then use, kind of a needle to insert the gel between the prostate and the rectum. I think it's fairly well tolerated. In all, transparency, I don't do this particular procedure. There are several urologists within urology clinics in North Texas within our group that do it. And so if this was something that you became interested in, you certainly can talk to your urologist here, and we'd be happy to get you referred to someone within the group that does it prior to your radiation treatment. Yeah. And we talked about that. So go to the next slide. And so, I think we've covered that as well. And these are kind of some next steps. You can see that later on the slides about if you're interested in SpaceOAR. So let's talk a little bit about, I briefly covered some treatment options. I talked about some side effects. And look, because prostate cancer is so treatable, because the vast majority of men are even cured, with prostate cancer treatment. There's a lot of survivors. There's over, 3 million, or there's nearly 3 million men in the country that are prostate cancer survivors. And like we've talked about, probably the two most common side effects that we see with prostate cancer treatment are urinary incontinence, bladder leakage, and erectile dysfunction. So I'll talk a little bit in the next few slides about how to treat some of these issues. So, after, like we've talked about, after prostate cancer treatment, men will have varying degrees of leakage, and many men will restore their continence. Their leakage will will resolve with time after treatment. But what we know is that after surgery, up to 10% of men do not get control of their urination. They are leaking, but if you're in this group, there are several options that we're going to talk about. Next slide. So, and this kind of illustrates what I just told you. 1 in 10 men after prostate removal will still have some leakage. And so let's go through, kind of all of the options, starting with, the options for just low volume leakage. Okay. So what if you just have really mild leakage, like, a drop here and there, or if you're really active, you sneeze with a full bladder, that sort of thing. Well, you may think about, some of the just kind of Band-Aid type measures is what I call them. You may have to just wear a pad when you work out or when you're really active. We have there for older men, maybe who aren't good surgical candidates or good. The other treatment options are not advisable. You can use a clamp. They make very soft clamps you can put on the penis. The main thing that I do in this category of people with really mild leakage is I send you to pelvic floor physical therapy. I have a pelvic floor therapist work with you to strengthen the pelvic floor, to regain some of the strength of the pelvic floor so that you have a better control. And we make a big effort there doing Kegels and also doing exercises with the therapist. Now, for moderate leakage, okay, for let's say, maybe you're using a pad today, at most, maybe 3 pads a day, but really more in the kind of 1-2 pads a day. We have several options. I think injections or bulking agents are an option. That's where we inject a bulking agent right at the neck of the bladder to try to bulk up your outlet so that, urine doesn't leak very easily. I think the real mainstay of treatment in this patient population, though, is what we call a male sling. And a male sling is basically a little piece of mesh that sits like a hammock underneath the urethra. And any time that you cough, you sneeze, you get up, you get in the truck, whatever, those moments when you're going to leak, okay, the sling will tension and it will kind of compress the urethra and prevent you from leaking. And I really like this operation. I do this operation regularly. It's an outpatient surgery. There is an incision right below the scrotum. Everyone goes home the same day. The great thing about this is that it uses your body's natural mechanisms. Okay, you don't have to do anything. You don't have to control anything. The sling gets put in, and then the results should be there, fairly quickly. Now, there's some pain and, of course, some recovery to the procedure, and it doesn't work in everyone. That probably works in if you look at the data, maybe 80% of men see significant improvement, maybe a little bit higher. But it's a great option with pretty minimal risk for men in this category. Now, if you have severe leakage, okay, or just, or if you've had radiation, like let's say you've had surgery, okay, and then you've had radiation after surgery, and then you have leakage. Typically in radiated patients, or in patients that have really severe leakage, we're going to recommend placement of an artificial urinary sphincter. And the artificial urinary sphincter has 3 components. There's a cuff that we put around the urethra that remains inflated at baseline so that it compresses the urethra so that you can't leak. And then when you go to the restroom and you want, let's say you want to void, you want to empty your bladder, you're going to pump this, pump within the scrotum. And that's going to kind of deflate the cuff that's around the urethra so the urethra will open up. You can void and empty your bladder. And then the cuff will automatically refill within about 90 seconds or so and compress the urethra again so that you become continent. And I think on the next slide, is this where we have, our demonstration. So this will be a video kind of showing you the functionality of the artificial urinary sphincter, okay? And again, I remember it has 3 components. So when you're ready to kind of void, what you'll do is you'll go and you'll reach down into the scrotum. You'll find your pump. You'll press it a few times. The fluid will leave the cuff, okay? And the urethra will open up so that you can void. And then within 90 seconds or so, the cuff will refill, compressing the urethra, and you become continent again. So basically all that you have to do as a patient is you have to press the pump in your scrotum once or twice when you want to void. And these are some more, links for you to help you understand some of these procedures, some of these concepts more. It also helps you to understand, like, where do I fall, like with the bladder leakage quiz, what degree of incontinence do I have? Am I a mild, moderate, or severe incontinence patient? Because that determines what treatment may be best for you. All right, and then, a sensitive subject, of course, but something that as urologists, we talk daily about is erectile dysfunction. And erectile dysfunction is going to happen for every man with time, okay? And over half of men, 65 or greater, are going to have, erectile dysfunction requiring treatment. Now, of course, in the prostate cancer population and those men that have been treated with surgery or with radiation, erectile dysfunction is going to be, very common. And, after surgery, what you'll see is that the erections will be pretty poor sometimes after surgery, even with nerve sparing. But over the first 2 years after surgery, you can regain some of your erectile function over time. Now, with radiation, what I typically find is that the erections are pretty good at first, and then it's kind of a slow fade over several years after radiation. You'll probably have difficulty with erections. So there are, different treatment options depending on, again, on the degree of your erectile dysfunction. Okay, next slide. So, where most people want to start, of course, is oral medication. Excuse me. And, there are 2 that are generic now. Okay, Viagra and Cialis both have a generic counterpart. Sildenafil and tadalafil, and men will typically want to start with medication. And I think that's fine. I think medication can be inconsistent. I also think medication is typically less effective in men with diabetes. And it's not super effective in men that have had a robotic prostatectomy if their erections have been impacted. But it's overall, a fairly easy place to start. But I find with more and more time in my practice that men can be displeased with kind of the inconsistency of medication or how it loses effect over time. There's mechanical ways to get erections. Certainly you can use a vacuum pump. You can see that kind of in the top right of the slide where you place a pump over the penis. You pump you use the pumping mechanism to create a negative pressure within the pump, which draws blood into the penis to give an erection. That's kind of a mechanical way to do it. I mean, it's nice, not a medication. It takes a lot of dexterity, though. It takes a lot of patience. It takes a partner who's understanding. So I don't find that compliance with pumps is super high, but certainly I have a few patients in my practice that swear by it, and there's not a whole lot of risk to it. Other, treatments, we do penile injections very commonly, especially after treatment for prostate cancer, at least initially. And this is where you inject a small amount of medicine into your penis immediately prior to sexual activity. You have to do it every time you want to have an erection. It can be fairly effective, but it tends to lose its effectiveness over time. And then, of course, men don't love injecting themselves, but For some men, this is a very viable option and they're happy. Some people will use urethral suppositories. That's like where you take a little tablet and you insert it into the hole you pee out of, and then it dissolves and it gets absorbed by the urethra. Honestly, I don't really love this option. It's not readily available anyways, and it causes some discomfort. It's not very effective. So I don't use it heavily in my practice. I think the kind of the most, I guess the most invasive, but the most definitive and kind of the last line of defense, okay, is a penile implant. And it doesn't necessarily have to be the last line of defense. You can jump some of these other treatments and go to implant first. But this is basically where we put a device within your penis, okay, that you'll inflate to give yourself an erection. And this doesn't affect your sensation. It doesn't affect your ability to orgasm. Everything functionally is the same, except that, it's a device giving you the rigidity you need to be sexually active. Now, I know that every time I bring up a penile implant in clinic, it feels like a jump, and I get that. It feels kind of difficult because, we're not all sitting at the coffee shop talking about penile implants, but the reality is there's a lot of men walking around with a penile implant, and it can keep you functional later in life. Most of the time, this is done as an outpatient procedure. The patients can also stay overnight, doesn't matter. But, it's what's great about it is that once you have an implant put in and you get through the recovery, which is the toughest part, and you learn how to use it, it's so consistent. And if you want to be sexually active multiple times a day, you can. You don't, I think most men that I'm putting implants in, they've really struggled with the kind of the inconsistency of the other treatments or the inconsistency of their erections. And that's the best part about an implant. So this is kind of a picture of probably what we would say is the most common implant. And that's a three-piece device, okay? And basically it's a three-piece device because it has, again, three pieces. Probably the most important piece to you would be the cylinders, which are placed within the penis. And these will fill with fluid when you want to have an erection, and they will give you the rigidity that you need. You'll control that fluid getting into those cylinders through a pump there in your scrotum. So very similar, right? Remember how we used a pump in the scrotum for the incontinence device? The pump for the penile implant is a similar thing where you'll pump it, but you'll have to pump it several times to kind of get the device inflated, and then you press a button on the pump, and the fluid will leave the cylinders and go back up into that reservoir, which is up in the pelvis there. You can see it being pointed out. And that basically just holds the fluid when it's not in the cylinders. It gives us a place for the fluid to go. And the reason that's important is because that allows your penis to become completely soft because there's no fluid in the cylinders. So if you want kind of the natural, be soft when you don't want to be sexually active, and then, the rigidity when you do, then the reservoir, the three pieces are really important. And this is all internal, okay? So here's a video to demonstrate some of what I've just said. And so we'll see here kind of the functionality. Again, so what's going to happen is they're going to find the pump in the scrotum, okay? They're going to squeeze the bulb, okay, or the pump there, and then see how fluid is leaving the reservoir in the pelvis and coming into the cylinders to give an erection. So the cylinder is filled with fluid. Now, to deactivate it, you find the button, okay? You press the deactivation button, and the fluid goes out of the cylinders back into the reservoir, okay? And so, all of this is internal, and you can't see any of it. There's just one incision typically when I do this procedure, okay? This, again, are some resources for you if you're struggling with your sexual function or erections. And, some questions that we get, I think I get the last one a lot, like, is a penile implant going to be covered? The coverage rates are pretty good. It's almost always covered by Medicare, essentially always. And in commercial plans, it can vary, but I think I hear anything from 75, 80% coverage in commercial plans. And so, yeah, I mean, it's more covered than you would probably anticipate. And so, yeah. And then these are just some, of course, some patients that have gone through treatments for incontinence and treatments for erection issues. And of course, their quality of life has improved. I think Boston Scientific, who's helping put on this webinar, has a documentary series called, I think it's called Hard. And that's looking at men who've had implants put in, and it interviews their families. And, I mean, this doesn't have to be kind of this, I guess, how would I say it? It doesn't have to be something you shove underneath the table, and I think sometimes we don't realize maybe how our quality of life can be improved, and so encourage you to watch that. But yeah, so I think, the overarching message is, certainly in men that have been treated for prostate cancer, these are issues. But there are options. I can't tell you how many men I meet kind of every month that have been dealing with erection issues after treatment for prostate cancer for 8, 10, 12 years and have just never really done anything about it, or men that have had incontinence for 20 years after prostatectomy and never really done anything about it, and there are options. I'm not saying that a lot of times it's a surgery. It's another procedure. There's some recovery to it. So there is a cost on your end, not necessarily, I'm not saying a financial cost, I'm just saying a personal cost to where you're going to have to devote some time of your life to go through it. But if it's that detrimental to your quality of life, let us help you. And I would encourage you to talk to your partner, and I'd encourage you to talk to your urologist.